On episode 199 of the 40 Plus Fitness podcast, we meet with Dr. Anna Lembke and discuss her book, Drug Dealer MD. You can find the full show notes for this episode at 40plusfitnesspodcast.com/199. Have you decided you're ready to make a change? To reclaim your health and fitness? The 40 Plus Fitness podcast is here for you. I'm your host, Alan Meisner. I'm an NSAM certified personal trainer with a specialization in corrective exercise and fitness nutrition. Let me be your coach as you find your way on your health and fitness journey. All right, let's go. So today's topic, dealing with pain med addiction, is kind of a sensitive topic. I know a lot of people out there deal with this. Obviously, the stats in the book don't lie. So this is probably an episode that may not directly relate to you, but could relate to someone that you know. If you get something good out of this, please go share the book with them. Dr. Lembke is an assistant professor at Stanford, and she's the chief of addiction medicine. So she knows her stuff, and this is a real good interview. I hope you enjoy it. So with no further ado, here's Dr. Anna Lembke. So Dr. Lembke, welcome to 40 Plus Fitness.
Thanks for having me.
This topic with drug dealer MD is kind of a topic that's close to heart. I have had some family members that have had some issues with painkillers, so it is something that kind of touches close to home with me, and something I really do want to share today. And I'm really, really happy to have you on the show.
Well, thanks so much for having me. When I wrote this book, I really wanted people who themselves are struggling with prescription drug misuse or have a family member struggling with prescription drug misuse to read this book in order to really understand what's happening.
Yes. And I'm going to read a little section of this. And when sometimes I see statistics, I see things like this, and it just kind of hits me in the gut. But you said in here, on November 1st, 2011, the Center for Disease Control and Prevention, the CDC, the agency of the government responsible for protecting Americans from major health threats, declared a prescription drug epidemic. And the CDC was unequivocal about what had caused the epidemic: prescription opiate painkillers and psychotherapeutic drugs being prescribed more widely by physicians. And a little bit further down, you have pharmacy retail sales of opiate painkillers obtained through a doctor's prescription quadrupled between 1999 and 2010. And I was thinking, wow. I mean, because you could sit there and say, the population of the United States went up a little bit. The number of people on, maybe insurance went up maybe a little bit in that time. But the quadrupling, just, are we getting hurt that much? And it was like this, kind of bell went off in my head. It's like, wow, this is huge.
One of the major messages I want people to understand is that the current prescription drug epidemic is first and foremost an epidemic of overprescribing. And there are so many factors that go into a doctor overprescribing prescription drugs. And it's so complex. It's not any one doctor's fault. It's not the patients coming in who are to blame. It's a very complex web that both patients and doctors find themselves trapped in. And that's really what I wanted to get at with the book, is for people to see all of the layers of this complex issue that have contributed to this perfect storm of today's prescription drug epidemic.
Yeah, so about 4 years ago, I went through a surgery. I had a hernia, and so I went in and had the surgery done. And, the doctor, of course, is like, take this for inflammation, take this for pain. And just, me not knowing any different, I'm like, well, I don't know how I'm going to feel tomorrow, so I'll go ahead and fill both these prescriptions. I ended up with those pain pills. I didn't take a single one. And so now I had this bottle of pain pills in my house, and I'm like, what am I going to do with these? Because I don't want to flush them. I don't want to get them into the water supply. So I buried them in my backyard.
Oh my God.
but it was like, I didn't know how much pain I was going to be in the next day. So I didn't want, to have to burden my wife and say, you need to go leave work and go get this for me now because I'm laying here in pain. So I went ahead and just got them filled, but I never had to take one. And
yeah, you've got some really happy plants right now.
Yeah, well, they were out of date, so probably not as happy as they would have been if I'd have buried them a little earlier. But I guess the thing that kind of hits to me is, and I've always thought this because as I done a lot of things in my life where I was in what I call pain, and the doctor would ask the question, the 1 to 10 number, and for me it's always like, well, I don't know, a 5 or 6, even though I think for a lot of other people they maybe they feel pain differently, and you kind of go into the history of that. Could you talk about the history of pain management and how maybe, I don't know, maybe we're affected by pain a little differently now, or we think about it differently?
Sure. Prior to 1980, doctors were very reluctant to prescribe opioid painkillers long-term for pain. And the reason they were reluctant to do that is because they were worried about patients getting addicted. This country had withstood 2 major opioid epidemics, the first in the early 1900s when heroin was sold over the counter next to Bayer aspirin as a pain reliever. And then ultimately during the Vietnam War, when we had a lot of vets who got addicted to heroin over in Vietnam, some of whom continued to struggle with that problem when they came back here. So there was good reason to proceed with caution. But what happened in the 1980s was that there was a recognition within the medical community that we were not doing a good job targeting pain. And to tell you the truth, we're still not doing a very good job today. But what some doctors decided was that maybe we needed to prescribe opioids more liberally. Maybe there were situations when opioids were really the right intervention. And in truth, opioid painkillers used short-term, let's say no more than a week, maximum a month, for pain are an absolute godsend. They work miracles to alleviate pain. The problem was that there started to be a movement to advocate for doctors to use opioids chronically, more than a month, more than 3 months, to use opioids for chronic pain conditions, and it essentially devolved into using opioids for minor medical problems. So the kinds of situations where previously, a doctor would never imagine prescribing opioids, it then became commonplace to prescribe them. And to give you one recent example, in Utah, almost 50% of pregnant women on Medicaid have received an opioid prescription for pain, for abdominal pain, for back pain, for whatever variety of pain. Now, pregnancy is not a pathological state, and it certainly is a temporary condition. And yet we have pregnant women all over the country taking opioids for really what previously would have been considered kind of normal and natural, a little bit of pain while you're pregnant, even potentially a lot of pain, but an endurable condition given the circumstances with a finish line that doesn't need to be medicated. This really shifted in the last 30 years with doctors just prescribing opioids for all kinds of minor ailments and then continuing to prescribe them long-term to the point where patients were getting addicted, patients were accidentally overdosing, and patients were ending up with all kinds of long-term adverse consequences. Now, you describe your particular unique situation. For whatever reason, maybe genetics, maybe environment, maybe your lifestyle, you were not inclined to take the opioids prescribed to you for your pain. But there are some people who are vulnerable to the physical effects, the euphorogenic effects, the whatever effects of opioids. And those people, once prescribed, even if they have a legitimate prescription for a legitimate pain condition, can go on to become addicted. And that's the risk that has really been underestimated. And that's the thing that we are now trying to change in medicine.
Yeah, because and we'll talk about Jim again later, but that's kind of the storyline with Jim was, almost the first time he had morphine pumped into a system in the hospital, he was done. Right,
and so that's a very good example of what we call cross addiction. So if you have been addicted to something in the past, even if you've been abstinent for years, if you're exposed to that drug again, or even another potentially addictive drug, you're going to get addicted much faster than somebody who has no history of addiction. Having said that, it is still true that you could have no history of personal addiction and yet get addicted to the drug prescribed by your doctor for a legitimate pain condition. I think this is really, an important take-home message. It's not just the previously addicted or the currently addicted who will get addicted to medications prescribed by a doctor.
Okay. Now, you had a section in the book where you talked about some strategies for drug-seeking patients, and I really like this section because I think it gives you that kind of maybe some of those warning flags that you can look for in your own behavior or the behavior of other people. So I do want to go through those if you have a few minutes for us to do that.
Sure.
Okay. So the first one, and I think you were really clear. It was good for you to put this in there that these titles are just titles to help people understand the nature of it. It's not demeaning, not meant to be demeaning of someone or speak poorly of them. It's just saying this is a behavior pattern, and this was just the best title to kind of hang on it. But the first one is sycophants.
Oh, yeah. So sycophants. So,
okay, sycophants.
So what does that mean? That means that, so when we talk about these strategies, first of all, what we're saying is this is somebody who is either already addicted to the prescription drug that their doctor is prescribing or on their way to becoming addicted. And so their behavior is driven by cravings and physiologic urges to use. And I really want to emphasize that because if we understand this behavior in the framework of drug seeking and addiction and physiologic craving, then I think it's a better way to understand it than to moralize and condemn these individuals, because addiction is characterized by manipulative behavior, lying, cheating, stealing, but it doesn't make that person necessarily a bad person. It makes that person an addicted person. Okay, so these different, quote unquote strategies are just a way of describing how patients who are addicted or becoming addicted go about manipulating their doctors to get the prescription that they want. And one of the ways they do that is to flatter the doctor, to tell the doctor how much better they are than any of their other doctors, how much they're helping them. And this really goes to the heart of the doctor-patient relationship because doctors go into medicine, to experience a patient's gratitude, to feel like they helped the patient. And so if you have a patient who's telling you how great you are and how much you help them, it's really, it has a very powerful, positive emotional effect on the doctor. And patients know that. And under those circumstances, doctors are probably more likely to continue prescribing in order to continue to get that good, positive feeling they get when patients express gratitude.
Okay. And then the senators.
Oh, yeah, the senators. So this is the filibuster technique. This is where patients wait until the last 30 seconds of the appointment to ask for a refill of their potentially addictive medication. They know that for the doctor to say, no, I'm not going to refill that, will lead to a complex discussion and probably crying and anger that will add, 20 minutes to their appointment and hence get them behind in their busy schedule. Whereas just saying yes to that and filling it out, then the patient's grateful. It takes 30 seconds. The appointment ends on time and off they go. So this filibuster technique is a technique whereby patients consciously or otherwise wait until the last minute before asking for a refill.
Okay. The exhibitionists.
The exhibitionists, these are the patients who have very dramatic displays of emotion or pain when they see their doctor. I have literally had patients undress almost completely in front of me to show me their various war wounds, some of which really are horrific war wounds. I've had patients writhing on the ground, really extreme displays of pain in order to communicate to the doctor that they really need the med.
Okay. The next one is losers.
The losers are the patients who tell you that they lost their prescription or they lost the bottle of pills. Water is a very common theme here. I lost it in the bottom of my fishing boat. I lost it in my toilet. It went through the rinse cycle. So if you have a patient who's coming in and repeatedly telling you that they lost their prescription for one reason or another, or the pills for one reason or another, you definitely want to wake up and pay attention. I have actually literally had a patient who told me that her dog ate her prescription.
There's the homework. Okay, the next one is the weekenders.
Yeah, so the weekenders, they're the patients who are very cognizant of sort of shift work in medicine now, and they will call in for an early refill on the weekends when they know their doctor's not around. If it's an academic teaching center, that's prime territory because they know the residents on call are less experienced or maybe so busy that they'll do anything to get off the phone, including refilling a medication without checking whether or not it's safe to do so.
Okay. And this next one I think is probably a very common one, is the doctor shoppers.
Yeah, so doctor shoppers are patients who go around to multiple doctors to get similar or same prescriptions. Fortunately, we now have prescription drug monitoring databases that allow us to check if the patient is filling a prescription for the same or a similar drug from other doctors. Unfortunately, most doctors still don't access these databases, so oftentimes they don't know.
Okay. The next one is the impersonators.
The impersonators are basically patients who, sort of like the reverse of doctor shopping. Instead of going around to multiple doctors, they just pretend to be multiple different people. So I've heard of patients who will show up to one emergency room as, Jim Smith, and then go, within 24 hours to another emergency room as, Jim Johnson. And so that tends to be a technique that patients will use.
Okay. And this next one's similar to the exhibitionist, but they team up, and it's called the dynamic duo.
Right. So this is typically a patient and her or his mother. And again, these are not necessarily conscious ploys, but they're just common patterns. The patient will be writhing on the ground. The mother will be crying 2 against 1. It's just so much easier to fill that prescription than to try to battle that.
Okay. And then the twins?
So the twins is my sort of my personal, let's say, most difficult type of scenario. And this is other healthcare providers, doctors, nurses, anybody in the healthcare field. When we identify with our patients, we tend to assume the best. We tend to think that they're like us. And if we're not actively addicted to prescription drugs, then we naturally assume that this physician or this nurse practitioner couldn't possibly be either. Also, people in the healthcare field tend to be very familiar with how a healthcare works, and so they're able to kind of navigate the system more cleverly. They'll often mention other doctors' names that you might know so that you feel like you're all part of one family network. So it's important to remember when you're seeing other healthcare providers that they are as likely as anybody to become addicted to prescription drugs.
Okay. And then we have city mice and country mice.
Right. So the city mice are the super savvy patients who will walk into the ER and tell the doctor that they're in pain and they're allergic to every kind of pain medication except for IV dilaudid push with a Benadryl chaser. When you get somebody like that who comes in specifically asking for a very potent intravenous formulation of a highly addictive opioid, you want to be careful. And then the country mouse is these are patients who seem really naive, don't seem to know anything about different types of pain medicines, might mention, I have a friend who I think she took something called Uxie or Oxy. And then since all healthcare providers are sort of natural helpers and codependents, the provider might say, you mean OxyContin? And then the patient will say, yeah, that's the one. And so you kind of get pulled into it without really realizing that really you're the third doctor of the day that this patient has gotten an OxyContin prescription from.
Okay. Now, the next one you say is quite effective, but I maybe that's why I'm not a doctor, because I don't know that I would respond very well to this, but it's the bullies.
This is the most effective. But you have to understand that the majority of doctors today are salaried employees working in large integrated healthcare systems. So there are enormous pressures on them to please their patients, to make sure that they get good patient satisfaction surveys. There are all kinds of, requirements and regulations. Anything you do in that kind of larger system has repercussions. And if you have a patient who's unhappy with you, that potentially will come back and impact your career adversely. So often these patients will threaten to sue or to call patient relations. Patient relations is a department of many large hospitals and clinics that deals with patient complaints. And if you get somebody calling patient relations on you, that's kind of terrifying as a physician, because, if you start to rack up a bunch of complaints, you could lose your job.
Yeah, it was funny. I was doing some teaching for an online university, and I had a student that that got a D. And the whole time through the whole semester, I kept trying to work with her. I'm like, okay, you're not making the grades on the exams. You're not doing your homework. What do you need? What do you need? What do you need? Well, she gets through, and I give her what she earned, the D. And she contacts me and says, well, I don't get reimbursed by my employer if I get a D. And I'm like, well, what do you think you earned? And that was the end of the conversation. And then I get a call from, basically, like you said, she turned me into their group. And so they're now investigating my class and investigating me through every class that I do. I start getting nasty emails from, this internal investigation.
Gosh.
And I'm like, I'm in a sense, I was doing the teaching because I enjoyed the topic and I enjoy helping people. And I just said, well, okay, it's easy enough for me to just say no, but I could easily, I can see where a doctor would say, this is my career. I can't just say no and walk away from it. But, so I guess I can see how that would definitely work in that scenario. Cause again, if someone threatens me, I'm like, I'll bow up and go with them. But, I can definitely see that now. So, internet copycat.
Yeah, I just wanted to comment on that because I think that's, it's a really sad state of affairs culturally now that we are in a situation from medicine to academia to you name it, where none of us feel we can legitimately criticize other people or call out, certain injustices for fear of, there's these kinds of sort of like repercussions. And it's just terrible.
Yeah, we've got some tough years ahead of us with some of this stuff of just the interpersonal relationships with people and where things are going. And I don't think it's Facebook and Twitter and those types of things that are really creating all of this. But I just think that this whole relationship and expectations and it's just a very interesting environment. And I being a doctor and having to deal with patients directly, I could just definitely see how that could be a problem. And it even in the personal training business, you have the same thing. Someone could go on to one of the rating sites and say bad things, or they can go on Facebook and say what they want, and Twitter and say what they want to say. And so it's a different world today.
It really is. Yep.
And so the next one is internet copycats.
Right. So, the internet is such this amazing resource of information, including for drug-seeking patients who can go on there and get advice from other patients about how to trick doctors to give them the drugs they want. And, that's a sad reality, but there's lots of good information on there for how to do that. And one of my favorite pieces of advice that I found on the internet was, just be a really good patient and only ask for a little bit more at every visit, and always tell the doctor what a good job they're doing. I mean, it really speaks to this deep awareness of, the doctor's need for validation, an awareness of the way that the system works, how doctors are fearful of being publicly criticized or sued. So it is really interesting.
Yeah, I guess I would just say read Dale Carnegie, because he wrote a book about winning friends and influencing people many, many years ago. So you probably, so that advice has been out there, not necessarily for this reason, but, treating people well is probably the best way to get what you need and what you want. Yeah. But unfortunately, that's not being used the right way here. And then the last one you have is the little engines that could.
Oh, yeah. So these are the patients who tell you that they absolutely want to get off, and it's their plan to get off, and they hate these medications, and they're all on board with the taper. But would you just refill, one more month because Aunt Judith is coming and she's really difficult to deal with. And plus, we have to move. And so I'm going to be doing a lot of lifting and all this. And every month they come in and there's sort of another good reason, to not start the taper or to continue taking the medication. And that's a common tactic.
Yeah, I guess I just, to me, pain has a purpose. As someone you go lift weights, and if you haven't lifted weights before, or you do a lift that you're unfamiliar with, or with a weight that you haven't done, you're very likely to feel some pain. And it's not a bad pain. It is a pain. And in many cases, if you get delayed onset muscle soreness, that pain could go on for a few days. people who lift regularly actually enjoy that pain because it tells us that we've pushed our body the way we need to, and it's a signal to us that it's time to rest. Let your body now recover from that work that you did, and you're going to come back stronger. So I guess I've always looked at pain and said that it's, and you said it in the book, it's natural. It's something you're supposed to have, and it's going to tell you, your ankle hurts. Well, don't walk on it because you twisted it, and you don't need to be walking on it.
Right. Something that I find very sad, because the benefits of exercise physically and psychologically, the evidence for that is so overwhelming. I mean, there's no refuting the intense benefits of exercise. And yet I see chronic pain patients diagnosed with things like chronic fatigue syndrome or fibromyalgia who are literally told by their doctors not to exercise, that breaking a sweat will cause their condition to worsen. And I'm quite sure that it's true that if they initially start exercising, it will be painful, but they've got to, it's like this pain phobia. They're so terrified of feeling their bodies in a certain way, and then they become trapped in this pain that is actually a result of not doing anything with their bodies. Anyway, it's a real tragedy.
Yeah. Well, the interesting thing is the same nerves that turn on a muscle to do the work are the nerves that are transferring the signal for pain. So a lot of times movement is actually a good placebo for medicine in helping you alleviate pain, is just movement, basic movement. And a lot of people don't understand that. So if you have DOMS, it's like move around a little bit, not a whole lot, don't lift anything, but just move those muscles. And that movement will actually cause the pain in your, the way you feel the pain to subside, because the brain can't send both signals through the nerves at the same time.
Sounds good to me, Alan. I'm all for that.
Okay.
Sign me up.
Now, again, the pain is a good signal. If you turned your ankle and you've hurt yourself and you've got the inflammation and the pain, you don't want to be running on that ankle and taking meds just to do something that you don't really need to be doing is not the right answer. But I found it kind of interesting towards we got to the end of the book. And, if the doctors are over-prescribing, it's because, and a patient's initially not going to ask for something typically until they know their insurance is going to pay for it. There's a situation with Jim where he was literally paying cash out of pocket to get the pills. And his insurance was getting angry with doctors for continuing to write these prescriptions. So it's very easy to get the insurance companies to pay for the prescriptions. But it's actually on the opposite side. Once you're addicted, can be quite difficult. And you had a stat in here that just, again, some of these things just punch me in the stomach. Today, addiction affects 16% of the U.S. population. That's about 40 million people, far exceeding the number affected with heart disease, which is 27 million, diabetes, which is 26 million, or cancer, which is 19 million. And I'm just like, so, if you actually do think of addiction as a disease instead of, again, them being a bad person, then the insurance companies need to step up, don't they?
Yeah, absolutely. I mean, this is the great hypocrisy in modern medicine today, that modern medicine the insurance companies will easily cover treatment for many what I call invisible disorders, from chronic pain syndromes to, late whiplash syndrome, Gulf War syndrome, all kinds of different syndromes, but they will not pay for addiction treatment. I'm happy to report that I think this is slowly beginning to change. The Affordable Care Act actually helped in this regard, stating that treatment for addiction and mental health disorders is an essential health benefit, meaning that insurance companies are obliged by law to cover addiction treatment. But in reality, on the ground, they still find ways to avoid it, lots of loopholes, demanding prior authorizations or this or that to sort of avoid treating it. So we've got a long way to go, but I feel like I feel like things are shifting in a positive direction.
And so, again, I think if someone's dealing with addiction, either themselves or a family member, and they're involved, it's incumbent on you to push, because the system will move. It's big and slow, but it will move if you push hard enough for what your needs are. And I know you had a conversation with an insurance. You mentioned it in the book, a story where you're calling an insurance company to explain why you're doing exactly what you're doing to treat the fact that they have pain and addiction. You need to treat both of them. You can't just treat one and not the other. And
right.
So I just thought that was pretty compelling. And then again, and I'm not
actually, I was yelling at the insurance company. I was just calling them. I was like, I'm going to call my local newspaper if you don't.
You're being a bully. You're using one of the.
Oh yeah. But that's it. I actually temperamentally. That's why bullying actually doesn't work for me, because when patients get up in my face like that, then that just drives me nuts. But there are a lot of doctors for whom that's temperamentally that's really scary. And they bullying will make them prescribe. So
I would imagine the insurance companies get yelled at a lot, but again, it is something
for a good reason.
But you have to fight for your health, and I've had other doctors on here, and we've talked about that you have to take healthcare into your own hands. There's a system there. You have to push it, and you have to make it work for you. Again, there's so many people affected with this that I just know that this is going to be a great book for folks to take into hand. And I appreciate the opportunity to talk to you and to read the book.
Oh, well, my pleasure. Thanks for getting the word out. This important message, consumer beware when being prescribed any controlled drug, because chances are your doctor doesn't really appreciate the risks involved.
Okay. And I really enjoyed how you laced this whole book with the story of Jim. I'm not gonna give away the ending, but I think it's worth folks getting into because it is a compelling story that I think is being replayed millions of times in this country, and I do hope folks will get this book and learn the lessons from it.
Thank you so much.
So if you wanted me to send somebody to get in touch with you or learn more about this or to get the book, where would you like for me to send them?
The book is available wherever books are sold. You can go on Amazon. You can go to my publisher's website, Johns Hopkins University Press. If you just Google drug dealer MD, and I don't even think you need to Google anything more than that, you'll find multiple sites where the books is sold. Actually, they're currently out of stock on Amazon. I guess it's selling well.
Good. Congratulations.
Thank you, but likely to get in more copies soon.
All right. Well, this is going to be episode 199, so you can go to 40plusfitnesspodcast.com/199, and I'll make sure to have the links for the book there. Again, Dr. Lembke, thank you so much for coming on to 40 Plus Fitness.
My pleasure.
So I hope you took something valuable from today's lesson. And if you know someone who either is directly or is related to someone or dealing with someone that is suffering from issues with pain meds, would you please share this episode with them? I think they'd get a lot out of it. Thank you. Next time on the 40 Plus Fitness Podcast, episode 200, I'm going to go over the essentials of strength training. Until then, have a happy and healthy day.